I want to thank all of you for joining us this evening and hope you are all staying safe and healthy, both during the pandemic and this week during the fires in Orange County. I want to express my deepest gratitude to all of the first responders in both the COVID pandemic and the fires this week. This evening, I will be sharing with you topics that are very important to me. First, can someone tell me if my screen is showing up?
Yes, we can.
Yes, Doctor.
Thank you. So I will be telling you about some topics that are very important to me and that I feel very passionate about, both colorectal cancer prevention and about newer, more minimally invasive procedures for gastroesophageal reflux disease. Let's get started. Colorectal cancer is very common. Approximately 5% or 1 in 20 people will get colorectal cancer during their lifetime. It's the 4th leading cause of cancer in this country, the 2nd leading cause of cancer deaths. Fortunately, the incidence of colorectal cancer is decreasing over time, as is the rate of deaths. As you can see here, the rate of decrease in colorectal cancer incidence and mortality started when the colorectal cancer screening programs started in the 1990s, and especially when lower endoscopy or colonoscopy was instituted as the main screening method for colorectal cancer. And keep this slide in mind, because the slide looks very similar to this graph, which has nothing to do with colorectal cancer. It actually has to do with the vaccine, the polio vaccine in the 1950s. And we see that when the polio vaccine was instituted, the rate of polio significantly decreased and became completely eradicated. And let me go back one slide and we can see how this graph really mirrors the polio epidemic, and that with the institution of colorectal cancer screening, we can also eradicate colorectal cancer. However, colorectal cancer is increasing in young people, and I'm sure you all have heard this because it's been all over the news. But this was initially discovered in 2010 and was shown in 2020 that by 2030, the rate of colorectal cancer in young people is expected to almost double. And this was a study in 2017 showing that in young people, so we see the first 4 graphs showing that in young people, the rates of colon cancer is increasing over time. Whereas in patients over the age of 50, the rates of colon cancer are decreasing over time. So there's a discrepancy in the incidence of colorectal cancer by age. Rectal cancer is particularly increasing in incidence in this country, and by 2030, the rate of rectal cancer is expected to more than double. This is the more updated study showing that rectal cancer is rapidly rising in the young groups ages 20 to 40, but rectal cancer is also decreasing in the age population that is being screened. In one of the more updated studies, we again see that over time, the mean age at diagnosis of colon and rectal cancer is decreasing, which means people are being diagnosed on average at a younger age. The percentage of patients diagnosed under the age of 50 is increasing. As you can see, that is both the case for males and females. So as we can see, there's a rising proportion of colorectal cancer cases diagnosed under the age of 50. More than 12% of patients now that are diagnosed with colorectal cancer are diagnosed younger than the age of 50. And this is even more predominant in African Americans and Hispanics. Younger patients, however, are more likely to have more aggressive disease and present with and die of more advanced stage colorectal cancer at 51.6% of those who are diagnosed, versus only 40% of those who are diagnosed over the age of 50. As with all malignancies or cancers, colorectal cancer is diagnosed in various stages, 1 through 4. And for colon cancer, a stage 1 colon cancer is isolated to the wall of the colon. A stage 2 colon cancer has more deeply invaded into the walls. Stage 3 has started invading into the lymph nodes. And stage 4 has started spreading to farther organs. This is important because the stage of a cancer determines the prognosis, or how well a patient will do. And as we see here on the graph on the right, the prognosis for patients with stage 1 and 2 colon cancer is excellent. Over 90% of patients survive at 5 years. And yet at stage 3 or 4, especially stage 4, the prognosis is not as good. And at 5 years, there's about a 13% survival. For colon cancer in particular, this is important because over 90% of patients who are diagnosed with stage 1 or 2 colorectal cancer are diagnosed at a screening exam, which means they never had any symptoms and it would never have been detected were it not for the screening exam. However, for patients with symptoms from colorectal cancer who present to their doctor, over 50% of those patients are diagnosed at stage 4. Which means we need to do the best at screening for this so that we can detect this disease early rather than wait for symptoms to present, because at that time it's often too late. These are some symptoms of colorectal cancer, and I don't mean to scare you because I don't want you to think that you have colorectal cancer just by reading any of these symptoms, but these are potential symptoms that patients with colorectal cancer can present with, including bleeding from the rectum, blood in the stool, dark or black stools, a change in the shape of the stool, especially more narrow caliber stools, lower abdominal cramping or discomfort, an urge to have a bowel movement despite the bowel being empty, which we call tenesmus, constipation or diarrhea lasting more than a few days, decreased appetite, unintentional weight loss, or anemia. Let's talk about the risk factors for colorectal cancer. And we can separate these by non-modifiable and modifiable risk factors, which means that non-modifiable risk factors we can't do anything about. Modifiable risk factors we can do something about. Let's first talk about non-modifiable risk factors. The biggest risk factor for colorectal cancer is having a polyp, because a polyp is a precursor to all colorectal cancers. Polyps are benign but precancerous growths, and polyps are also known as adenomas. There are two main types of adenomas, and this is definitely simplified, but the most common type of adenoma is a tubular adenoma, which generally is slow growing and takes 10 years to turn into cancer. The other type of adenoma we don't hear as much about, but gastroenterologists have increased awareness about these, are called sessile serrated adenomas. And we'll talk a lot more about these because one of my goals is to raise awareness about this particular type of polyp. This particular type of polyp can grow even more quickly into colorectal cancer and take only 3 to 5 years to do so. There are many other types of polyps that are not precancerous, which means they don't have any malignant potential. And some examples include hyperplastic polyps and inflammatory polyps. The reason I'm going through these in detail is because many of you may have seen these terms mentioned on your colonoscopy and pathology reports. A history of an advanced adenoma or an advanced polyp is especially increases the risk for colorectal cancer. And examples of advanced colon polyps include those that are large in size, meaning greater than 1 centimeter, or that have advanced features under the microscope when the pathologist looks at them, such as villus adenomas, tubulovillus, or polyps with high-grade dysplasia. Again, these are higher risk and increase the risk of cancer even more. Here are some examples of some tubular adenomas, which can start off as small polyps or medium polyps or very large size polyps. And though this type of polyp looks large and scary, it is technically still benign and still can be removed before it turns into colon cancer. Here are some examples of the sessile serrated adenomas I was mentioning. As you can see, these polyps are more subtle. They're flat, they are more difficult to find. And we see pairs of photos here because we'll go over this in more detail, but we see that these polyps can more easily be detected when we use various techniques during colonoscopy, such as changing the light to a blue light to detect these flatter, more subtle polyps. Age is another risk factor, and age, as we get older, the risk of colorectal cancer increases, but it dramatically increases after the age of 50. And over 90%, about 90% of colorectal cancers are diagnosed in patients who are over the age of 50. And the average age of diagnosis is 72, but it is decreasing as we saw earlier. Sex, race, and ethnicity are definitely risk factors. As we see here, males overall have a higher risk of colon cancer than women. The incidence and mortality are 30 to 40% higher in men than women. However, there's a larger proportion of tumors in women that are in the right side of the colon as opposed to in men. Race also is a risk factor. And as we see here, non-Hispanic Blacks are at the highest risk. And Asian Pacific Islanders, which many of us are at the lowest risk. But as you see here, there is still certainly a risk of colorectal cancer in Asians, especially South Asians. And I have diagnosed many South Asian patients with colorectal cancer. So we are not completely protected, which is something that that I hear from patients, that they think they might be completely protected because they're South Asian. Having a history of colorectal cancer does increase the risk of all second cancers. And so the risk of colorectal cancer increases in patients who have had another cancer, but at the same time, in patients who have had another cancer, the risk of colon and rectal cancer does increase for them as well. A family history of colorectal cancer is definitely a risk factor. And as we see here, patients with a first-degree relative or any relative with colorectal cancer diagnosed under the age of 45 or greater than one relative with colorectal cancer have a significantly increased risk. In a more updated study from 2014, we see that not only do patients who have a first-degree relative with colorectal cancer have an increased risk, but also there is somewhat of an increased risk in patients who have a second-degree relative or a first cousin who has had colorectal cancer. And these types of relatives are actually not incorporated in the guidelines as to determining who is at higher risk. In a patient who has a first-degree relative who has had colorectal cancer, their risk of colorectal cancer is not only elevated, but their risk of adenomas or polyps is also elevated. Other non-modifiable risk factors for colon cancer include various hereditary polyposis syndromes, which means someone who has inherited genes from their family members that predispose them to increased risk of colorectal cancer. The most common hereditary polyposis syndrome is Lynch syndrome, which accounts for 3% of colorectal cancer. Lynch syndrome also confers an increased risk of endometrial or uterine cancer, stomach cancer, ovarian cancer, urinary cancers, and other cancers as well. So it's important to be aware of other family members who have had a history of these other types of cancers, in that there might be a heightened risk of colorectal cancer as well. In patients with Lynch syndrome, there is a significantly high risk of lifetime risk of colorectal cancer of 66% in men and 43% in women. And the age of diagnosis is much younger, at 42 in men and 47 in women. There are various other hereditary polyposis syndromes, which I won't go into detail. But inflammatory bowel disease, such as ulcerative colitis or Crohn's disease, especially Crohn's that affects the colon, does confer an increased risk of colorectal cancer as well. But talking about this would be outside the scope of this talk. Let's now talk about some modifiable risk factors, things we can do something about, which might be even more important because these are things that we can make a difference in our own lives. Having type 2 diabetes confers a 20% increased risk, even after accounting for physical activity, body mass index, and waist circumference. And diabetic patients who get colorectal cancer do have a poorer survival than their non-diabetic counterparts. Physical activity, or lack thereof, certainly is an increased risk of colorectal cancer. And the most physically active patients have a significantly lower risk of colorectal cancer than the least physically active patients. Being less active does increase the risk of death from colon cancer as well. The more physically active we are, the lower our risk of colon cancer. And both recreational and occupational physical activity decreases our risk. So if we get a lot of physical activity from our work, that also counts. The risk is reduced for sedentary people who become active later in life. So it really is never too late to become active. And we see here in the US, the CDC and the American Cancer Society recommend at least 150 minutes of moderate intensity activity per week, or at least 75 minutes of vigorous intensity activity per week. And only half of US adults meet these guidelines. And I can admit that I don't fall into that half. Being overweight or obese does significantly increase the risk of colon cancer. We see a 20% increased risk in obese patients and a stronger link in men. This is independent of physical activity, and abdominal obesity, and especially waist circumference, is more important than overall obesity. Diet and habits are also risk factors, especially red and processed meat confer a 20% increased risk of colon cancer. Moderate and heavy alcohol use increases risk, especially drinking more than 2 to 4 drinks per day. Smoking also increases the risk, but as we see here, there's a latency of 3 to 4 decades, which means smoking earlier in life leads to an increased risk later in life. This map is very interesting because it shows on the top map the incidence rates of colorectal cancer, and the dark colors are the countries that have a higher rate of colorectal cancer. And the bottom map looks very similar to the top map, but the bottom map shows the countries that have a higher red meat consumption. So we see here that there's a very strong link between the consumption of red and processed meat and the risk of colorectal cancer. But again, I've diagnosed many vegetarians and vegans with colorectal cancer, so we are not completely protected. There are certain protective factors, however, that can protect us or lower our risk of colorectal cancer, and increasing our intake of dietary fiber, cereal fiber, whole grains, fruits, vegetables, especially fresh and raw fruits and vegetables, dairy, milk, calcium, vitamin D, folate, even coffee and yogurt and fish have been found to decrease the risk of colorectal cancer. So a summary of the ways to reduce the risk of colon cancer is as follows. We can minimize risk factors such as obesity, red and processed meat consumption, alcohol consumption, smoking, and inadequate physical activity. We can maximize preventive factors such as increasing our physical activity and increasing our intake of fiber, fruits, and vegetables. Certain medications have been found to decrease the colorectal cancer risk. However, these are not recommended to be taken by themselves to reduce the risk because they can have their own risks as well, such as aspirin and NSAID medications. Postmenopausal hormones have been found to reduce the risk of colon cancer, but have been found to increase the risk of other cancers. So again, there are risks and benefits with all of these interventions. There's a slight decreased risk from oral bisphosphonates, which are used for osteoporosis and oral contraceptives as well. So we talked about the ways to decrease our risk of colorectal cancer, but let's switch gears and talk about screening for cancer versus prevention of cancer, because these are very important distinctions. And though these are very similar concepts, screening and prevention, if you think about them, they are actually quite different. Screening for a disease means to detect it early after it has already developed. And we do that often with other types of cancers, such as breast cancer, prostate cancer, lung cancer. We screen for these diseases, and our goal is to find them early, but after they have developed. However, preventing a disease before it ever develops would be even better than screening for it, because then we could prevent it before it ever happens. And colorectal cancer is one of the few cancers that we can prevent rather than just screen for it. So as we see here in this message by the American College of Gastroenterology, Prostate cancer, breast cancer are examples of cancers that cannot be prevented, but they can be screened for or detected. Colorectal cancer can be prevented, not just detected, and the only way to do so is with colonoscopy, and we'll talk about that. Let's first talk about screening, however. Again, screening means detecting the disease after it has developed, and there are various methods to screen for colon cancer, including the following. A sigmoidoscopy is a camera through the rectum, but not the entire colon is not examined. And this is recommended if it's done, which is not it's not done very frequently now. It's recommended to be done every 5 years. And it has been shown to reduce the risk of colorectal cancer by 33% and reduce the mortality or dying from colorectal cancer by 43%. However, many gastroenterologists compare this exam to doing a mammogram on one breast. Less than half of the colon is examined, and a full colonoscopy is still needed if any polyps are found. A barium enema and CT colonography can be done, but they're not as commonly done. Barium enema is quite uncommonly done. A full prep is still needed, and it occurs when a radiologist injects contrast into the rectum, and a colonoscopy is still needed if any polyps are found. A CT colonography or virtual colonoscopy is a type of CT scan where a radiologist makes a 3D rendering of the colon and is able to detect polyps. But studies have shown only large polyps are able to be detected with this, and small and flat polyps can be missed with this exam. This is the exam that President Obama had. A full prep is needed, and again, a colonoscopy is still needed if any polyps are found. Here's an example. It's a cool technology, and here's an example of a 3D rendering of a CT colonography or virtual colonoscopy and a polyp that was found during that exam, and that same polyp that was found on a follow-up colonoscopy. But again, there's significant limitations to this. There are various stool tests to screen for colon cancer. Most of these tests are required annually, except the Cologuard, which we'll talk about. Stool tests can have a significant false positive rate, though, which means most of the time that the test is positive, it does not mean that there is a colon cancer and follow-up colonoscopy. Of course, these tests are very convenient in that they're non-invasive, but it does miss most polyps. And there are three major types of stool tests. One is called the FOBT, or fecal occult blood test. This has been largely replaced by the FIT test, or the fecal immunohistochemical test, which detects human hemoglobin, so it's more sensitive and more specific. And the Cologuard test is a stool DNA test. It's a newer test that has increased sensitivity. It finds 92% of cancers as opposed to about 80 to 85% of cancers with the older stool tests. And it can find up to 70% of polyps that are advanced with high-grade dysplasia. But the downside of that is that it has a high false positive rate. 13% of patients who have a positive, 13% of patients who do not have colon cancer will have a positive Cologuard test and end up needing a colonoscopy. So there's a high false positive rate. However, of course, there are benefits of a non-invasive test in that it's convenient and there's privacy and it's safe. There's no bowel prep. There's no need to take off from work or be sedated and have risks. But at the same time, it has good sensitivity for detecting colon cancer. Again, 92%, which means it could still miss 8% of colon cancers, and a high false positive rate, 13% false positive rate. However, colonoscopy is the exam that's able to screen for and prevent colorectal cancer. It is the gold standard, which means that all of the other tests that I just mentioned are benchmarked against colonoscopy to determine their performance. The only way to truly prevent colon cancer is by finding and removing those polyps that I mentioned that are precancerous growths, that are the precursors to colon cancer. Colonoscopy is able to reduce the risk of colorectal cancer by 90%. It reduces the risk of advanced stage colorectal cancer by 70%, and it reduces the risk of death from colorectal cancer by 53%. So it's a very effective exam. Here's a quick anatomy of the colon. We see here that it's in the shape of an upside down U. The colon is also known as the large intestine. It starts off in the right lower part of the abdomen called the cecum, and it goes up the right side, across the top of the abdomen, down the left side, makes a few twists and turns, and ends in the rectum. Here's a funny cartoon that a patient gave me and asked me to put in my talk. During a colonoscopy, a patient is usually lying on their side. They're usually sedated, which means they're given medicines to make them sleepy by IV. Then we insert a camera into the rectum that's about the size of my little finger, and we examine the entire 5 feet of colon with the camera. The camera has a light. The tube has a light and a camera at the end of it, as well as a channel through which various instruments can be passed. Here are some sample images of what we see during colonoscopy, and these are examples of normal colons. And if we find a polyp, we can do various things for it. We can remove it by something called a biopsy forceps. We can remove it by something called a snare, which is a wire loop that goes around the polyp, and we can either mechanically cut it off or use cautery or heat to cut off the polyp when it's larger. This is the most common and preferred and most recommended method to remove polyps. When there's a very large or very flat polyp, then more advanced techniques such as endoscopic mucosal resection or EMR can be done, but this should only be done in the hands of gastroenterologists who have special training in this technique. This is something that I do really enjoy performing, and I do receive a lot of referrals for this type of procedure to remove very large polyps. Other things we can happen to find during colonoscopy includes diverticulosis, includes hemorrhoids, includes ulcerative colitis, and of course we want to find cancers, and this is an example of one. So this is a repeat of a previous slide. So we talked about how great colonoscopy is. When we talk about it, we talk very highly of it. It reduces the risk of colorectal cancer by significant amounts, reduces the risk of advanced stage cancers, reduces the risk of deaths from cancers by significant amounts. But if you all noticed, this number here is 90%, which is high, but why is it not 100%? Why are we not completely preventing colorectal cancer? And why are we only partially preventing it with this exam? And I will tell you why. An interval colorectal cancer is one of our worst nightmares. It's a colorectal cancer that occurs within a certain period of time, usually 3 to 5 years after a colonoscopy, and it accounts for up to 10% of colorectal cancers. There's a higher percentage of these cancers that develop soon after colonoscopy in the right colon or the upper part of the colon, and these cancers that develop soon after colonoscopy are thought to be due to those more difficult to detect polyps. Remember those polyps that I did refer to that are called sessile serrated adenomas. What are risk factors for interval colorectal cancers? Risk factors include age, being female. Remember I told you that those right-sided cancers are more common in females, and we think that that might be why. Having a colonoscopy done that's by a doctor that is not a gastroenterologist has been proven in multiple studies to increase the risk of colorectal cancer, likely because of missed lesions. Having a colonoscopy done by someone who does not do many of them increases the risk of still having cancer, having diverticulosis, or definitely having an incomplete examination, meaning having had a colonoscopy but not the entire colon was not examined. All of these increase the risk of colorectal cancer soon after the colonoscopy. But one of the biggest risk factors for for developing cancer after colonoscopy falls on us gastroenterologists. And that risk factor is when a gastroenterologist has a low detection rate of less than 20%. We're going to talk all about detection rates, but that increases the risk of interval colorectal cancer by 10-fold. So significantly increased risk of this. And what are some potential causes of interval colorectal cancers? And when I give this talk to a live audience, I usually ask for responses, but I'll share the answers with you. But I want you to think about it before I share the answers. What could be causing these cancers that occur soon after having had a colonoscopy? Well, the reason falls mostly on us. Number one, we might be missing polyps or even cancers. Number two, we might be incompletely removing polyps, which in turn end up still turning into cancer. pathologists might be misclassifying polyps and telling us that they're benign and not precancerous when they actually are, or patients might have bad luck and just have a rapid progression of new polyps. But as we see here, most of the interval colorectal cancers fall on the gastroenterologists, in that most interval cancers are caused by either missed polyps or cancers or incompletely removed polyps or cancers. And this is the true and real secret to colon cancer prevention and making that number of colorectal cancer risk decrease to 100% rather than 90%. Let's talk about this even further and what we as gastroenterologists can do. Missed polyps is actually a significant problem. Patients don't hear about this much, but gastroenterologists fear this. We fear missing polyps, and colonoscopy is highly operator dependent. There are significant miss rates for polyps. Up to 22% of small polyps are missed in studies, and even large polyps, there's a significant miss rate of 12%. Even cancers can be missed, so no exam is 100%. Certainly colonoscopy isn't. We talked about the various types of polyps, and the tubular adenomas, the most common types of polyps, can hide, and that's how they can be missed. But those sessile serrated adenomas can be subtle and flat, and they can hide. So not only could they not be seen, even if they're right in front of us, but they can also hide behind folds. And here are some examples of polyps that are missed or that could have been missed. Polyps can hide. So this polyp is easy to see. This polyp is even easier to see. This polyp is very easy to see, but this polyp can be easily missed because it's hiding behind a fold. These sessile serrated adenomas can easily be missed because they're subtle. So even though they're right in front of us when we're doing colonoscopy, they're very flat and subtle and can be easily missed. They are often just detected by a subtle change in the texture of the colon walls. Here's an example of one of my patients in whom I did a colonoscopy for the first time. I thought I might have seen something very subtle in this area. And so I zoomed in and I saw a very subtle change in the texture of her colon in this area. I changed the light to blue, and certainly there was something in that area. And when I zoomed in, this is a sessile serrated adenoma that could have been easily missed. I removed her polyp with a snare, like so. And this is after it was completely removed. This is the same patient who had another sessile serrated adenoma, and it's extremely easy to miss these. It's actually a large flat polyp at the top of the screen here. And we change to blue light and we see some adherent mucus at the top of the screen, and that polyp is actually characterized by the adherent mucus. We call that a mucus cap. And we see here in the middle of the screen, the same polyp can more easily be seen. So these polyps are very subtle. This is the same polyp in the middle of the screen. Here's a polyp at the screen. I want you to think, again, when I do this live, I usually ask patients to try to find the polyp, but I still want you all to try to find the polyp. And think to yourself, is it at 12 o'clock, 3 o'clock, 6 o'clock, or 9 o'clock? And it is actually here at 7 or 8 o'clock. We can change to blue light and we see that the polyp can much more easily be seen with the blue light. The blue light is called narrowband imaging, which we'll talk about more. So what should we do as patients to find out about the quality of our gastroenterologists? Well, the American Gastroenterological Association encourages patients to ask questions of their gastroenterologists. They encourage patients to ask gastroenterologists, how often does your GI reach the start of the large intestine? How often do they complete the exam? That should be more than 95%. How often does your GI find polyps? You should be asking us, and we should be finding polyps in at least 25% of our exams. How often does poor bowel prep lead to incomplete exams? This is just a function of us prescribing the proper bowel prep. This should happen less than 15% of the time. And this final quality metric, it has to do with overutilization. Most patients don't need another exam for 10 years. And this is one of the most important concepts to understand, the adenoma detection rate. This is kind of like our report card or our batting average. And this is not something that's commonly published or commonly talked about, but it really is something that patients should be aware about because it is a true indicator of quality of a doctor. How do we define this detection rate or this report card? It is the percentage of first-time screening colonoscopies that we perform in which at least one precancerous polyp or adenoma is detected and removed. And studies have shown that there's significant operator dependence, that this adenoma detection rate can range widely from 7 to 52%. At the higher end, this likely reflects the true prevalence of polyps in the population, in that doctors who are detecting polyps in 50% of patients are likely finding that about 50% of the population has a precancerous polyp. We do have benchmarks that we do need to meet. And per the American Society of Gastrointestinal Endoscopy, we are expected to be detecting polyps in at least 30% of men, 20% of women, and 25% overall of our patients. And the most recent guidelines from our society states that the measurement of the adenoma detection rate is mandatory to appreciating whether colonoscopists should be performing screening colonoscopies. Patients should expect a prospective colonoscopist to provide his or her adenoma detection rate, which should meet or exceed recommended minimum thresholds. Our societies are saying that our patients should be asking us what our quality is. Here's the landmark study from 2014 showing that in patients who have had a colonoscopy by a lower detecting colonoscopist, they have a higher rate of developing interval colorectal cancer, a higher rate of developing advanced stage colorectal cancer, and a higher rate of dying from colorectal cancer. Another way of putting this is that patients who have an exam by a high-performing colonoscopist have a lower rate of getting cancer, a lower rate of getting advanced cancer, a lower rate of dying from colon cancer. And you see that these graphs are linear, which means the higher the quality, the lower the patient's risk. So what can we as gastroenterologists do to improve our adenoma detection rate? Or let's first talk about factors that affect our quality. And factors that affect our quality include how good the prep is, meaning if there's still stool left in the colon, we might be missing polyps. Other factors include withdrawal time. The more time we spend, the more likely we're going to be detecting polyps. Withdrawal technique, we want to be looking at the colon more carefully rather than looking at it carelessly. And certainly there's some technology that can help us with this as well. Let's first talk about prep quality. We actually rate you all in terms of the quality of your prep. We give you a report card, and there are various scores that we rate your colons by in terms of how well you prepped your colon. And we see here the Boston Bowel Prep score is the most commonly used prep score that we use, and everyone should be aiming for a perfect score of 9, which means a perfectly prepped colon in all 3 segments of the colon. Split dose is a very important concept that I still get a lot of questions from patients about. Split dose, which means taking half the dose of the prep the night before the procedure, half the dose of the prep the morning of the procedure. I have many patients who've had their colonoscopy 5, 10, 20 years ago and tell me, back then, I only had to take my prep the night before. I did not have to wake up early to take my prep. And the reason that this is so important is that over time, a sticky coating of bile forms on the surface of the colon. And as you can imagine, especially on those images that I already showed you of polyps, if there was a sticky coating of bile, I could have easily missed any of those polyps. So splitting the dose or taking half of the dose the morning of the procedure, irrespective of how early the procedure is, has been shown to improve the prep quality by over 3.5 times. And this is now part of national guidelines for all patients to take their prep in a split dose fashion. Let's talk about withdrawal time. The colon is 5 feet long, 3 inches in diameter. So if we calculate the surface area, it's 300,000 square millimeters. So how long do you think it would take to find a polyp that might be 3 millimeters in size in a 300,000 square millimeter surface area? Let's think about this. Well, the colon is not only that large in surface area, but it also has many folds. I like to compare the shape of the colon like an accordion, which has many, many folds, which, like we talked about, behind which polyps can easily be missed. So now think about how long we should be spending evaluating the colon to look for polyps in you. Well, our society says that the minimum time that we should be spending evaluating the colon is 6 minutes. In my opinion, and many others' opinions, including in studies that have been shown, 6 minutes might not be enough to evaluate and detect a polyp in 300,000 square millimeters of a colon that is in the shape of an accordion. And multiple studies have shown that the longer we spend looking for polyps, the higher our detection rate. It's not rocket science. That has to do with anything. The longer we spend looking for something, the more likely we are to find it. Withdrawal technique. So it's not just about time, but it's about carefulness. And the more careful we are in looking for polyps also has been proven to increase our polyp detection or adenoma detection. We are expected to be carefully inspecting the colon, especially behind folds and turns. We are expected to wash away any residual stool and take time to do so, but not everyone takes the time to do that. What are other techniques can we do? Well, here's an X-ray of a camera inside a patient's colon, and we can perform a simple technique called retroflexion, where we turn the camera and simply turn it around and make a U-turn with the camera. And as we see here, here are some examples of a colonoscopy in which the gastroenterologist retroflexed or made a U-turn with the scope, and we could easily see behind the folds now. We should be doing this, or at least attempting to do this, on every colonoscopy. And when we do it, we take pictures just as you see on the screen. So when you all get your colonoscopy, you can see whether or not your gastroenterologist retroflexed in the right colon. Here's an example of one of my patients in whom I retroflex the scope, and I do that for all of my patients. And I happen to detect a very large flat polyp on the back side of the fold, which I almost certainly would have missed had I not done this maneuver. And this patient's life was likely saved because this patient would have likely had a colon cancer develop from this large flat polyp. But fortunately, I removed this polyp and I brought her back, and that polyp was completely gone. Here's some videos to show you some examples of what I mean. So here's an example of withdrawal technique. So as you see here, when I'm doing this patient's colonoscopy, I'm washing away all of the adherent mucus and making sure that I can see and that I can inspect every surface that I see. Here's an example of retroflexing the camera. So I am now turning the scope around, and that's why I see the camera, and now I'm able to see the back sides of the folds. And in a moment, I'll be able to see an area right here. This is the ileocecal valve, and this is behind the ileocecal valve, which is the valve between the small and the large intestines. And that little crevice right there is the most common place for polyps and cancers to be missed. And the only way to really adequately detect that area, to visualize that area, is to retroflex the scope. Let's talk about other aspects of technique. So when we do a colonoscopy and we reach the appendix all the way inside and we start pulling the scope out and spending our minimum of 6 minutes, we could just start pulling the scope out slowly like I'm doing here. And I could spend 6 minutes doing so, but I certainly would be missing polyps between and behind folds if I withdrew the scope in this manner. Here's the same patient in whom I'm practicing proper technique of withdrawing the scope, and I'm doing a careful examination between and behind every single fold to make sure I'm not missing any polyps between and behind these folds. So this is very important for us to do. And it's again, it's not rocket science. The harder we look, the longer we take to look, the more likely we are going to find something, and the less likely we are going to miss something. So why does all this matter if you're going to be sedated for your exam? How will you all know how careful your gastroenterologist is during your colonoscopy? Because aren't these tips and techniques more for gastroenterologists and not for patients? Well, the reason this is pertinent to patients is that patients are now able to observe their own colonoscopies. There's an increasing trend to have colonoscopies without any sedation. This is the norm in the rest of the world. It's really in the Western world where it's become more of a convention to sedate patients. In the rest of the world, especially in Europe and Asia, the norm is to have colonoscopy without sedation. How can we do this? Well, we can be very careful when we insert the scope, and we can use various techniques such as underwater colonoscopy and loop reduction to make sure a patient stays comfortable during an unsedated colonoscopy. What are some benefits of doing this from the patient side? Well, patient can watch their own exam, and that allows for transparency. By human nature, when we're being watched, we end up performing better. It is very cool to watch your exam, and this has been proven to increase adenoma detection rate. Again, because when a patient is awake and engaged and observing our performance, we're going to end up performing better. When a patient does their colonoscopy without sedation, there's no recovery time. They can drive themselves home. They can go back to work. There's no risks of sedation. And in my patients who have their colonoscopy without sedation, over 90% of them express a willingness and actually would like to have their exam repeated the same way without sedation. What else can we do to increase our detection? Well, we should all be using high definition endoscopes, which, as you can see here, makes a huge difference in the quality of the exam. We can use various technologies such as a blue light, and every modern scope now will have this blue light, and it's just a button we press on the scope which changes the light to blue, and it helps increase the contrast and the detection of polyps that are more subtle, and in essence it allows us to examine the texture of the colon as opposed to just the contour of the colon walls. Again, here are some examples of those same sessile serrated adenomas that can much more easily be detected with this blue light or narrowband imaging. So this is an invaluable tool for us. Here are some examples, the same examples that I showed you of those polyps that I detected using the narrowband imaging or the blue light. And again, looking at these pairs of images, it's much more easy to detect these polyps when using the blue light on suspicious areas. There are various equipment such as, and one example is called the endocuff, equipment that attaches at the end of the scope to provide us with even more visualization during the colonoscopy. The endocuff device is one of the examples of that, and is probably the most common example of a device that has been shown to increase our detection rate. This device has had dozens of randomized control trials with thousands of patients showing an improvement in our adenoma detection rate. There have been 0 serious events reported, and so it's a completely safe device. The device is manufactured in the UK, and hence it's now been incorporated in the National United Kingdom guidelines, which are called the NICE guidelines, which state the following: clinical evidence shows that for people having a colonoscopy as part of screening, using the endocuff device improves the adenoma detection rate without increasing how long the procedure takes. Here is an animation of an example of how this device works. So again, it's a device that attaches at the end of the camera, has these flexible rubberized arms that flatten the folds of the colon to enhance views of the areas behind the folds where polyps are most commonly hidden and missed, as I explained to you. It's been proven to increase the adenoma detection rate by up to 50%. What are some other reasons that patients are getting colon cancer after their colonoscopy? Well, we might be detecting a polyp, but if we don't completely remove it, it might still turn into cancer. And the incomplete resection or removal rate varies widely among endoscopists at 6 to 22%. The incomplete removal rate is higher, as you can imagine, for larger polyps. And so for small polyps, the incomplete removal rate is only about 1 in 20. But for those large flat polyps, it approaches 30%. So it's absolutely critical for us to perform close follow-up exams after removing very large polyps, because these tend to grow back because they may not have been completely removed. Multiple studies have shown that we should be removing most, if not all, polyps with the snare, because when polyps are removed with the forceps, studies have shown a much higher incomplete removal rate. Endoscopic mucosal resection, as I mentioned to you earlier, is an advanced technique to remove very large polyps and should be only done in the hands of gastroenterologists who have had special training in this technique. Here's an example of a patient of mine in whom I saw for the first time and detected a very large polyp. In fact, this patient was seeing their previous gastroenterologist every year prior to seeing me and getting this same polyp removed every year, but it kept coming back every single year. And the reason was that it wasn't removed in the right fashion. When we perform endoscopic mucosal resection for large polyps, the complete removal or complete resection rate is much higher. And when I brought this patient back a year later, there was zero polyp in that area. Polyps can be misclassified. So we can detect polyps, we can completely remove polyps, but if a polyp is not classified properly by the pathologist, then it may result in an inappropriate recommendation that we give to you for the next colonoscopy. So in general, for 1 to 2 small polyps, we should be recommending colonoscopy 5 years later. Actually, this just changed to 7 to 10 years this year. 3 to 10 small polyps, 3 years. Any large polyps, 3 years. But if a polyp is determined to be one of those non-precancerous polyps called hyperplastic polyps, the guidelines say we should be recommending follow-up colonoscopy in 10 years. However, the scary part of this is that sometimes hyperplastic polyps are actually misclassified and they are actually precancerous sessile serrated adenomas. But for technical reasons, looking at these polyps under the microscope for a pathologist, it can be very difficult to impossible to distinguish between these two types of polyps. Like I mentioned, sessile serrated adenomas often get misclassified as hyperplastic polyps, and this might result in an inappropriately long interval until the next colonoscopy, which would hence increase the chance of getting colon cancer if that was truly a precancerous polyp. Here's a study that I was actually involved in at UC Irvine, comparing the performance of various pathologists and their classification rates between precancerous polyps and non-precancerous polyps. And we see a linear relation between their classification rates of precancerous and non-precancerous polyps, which means, to put things simply, pathologists vary widely in their patterns of classifying these polyps, which is a little scary. So these sessile serrated adenomas are the perfect storm. They're common, they're difficult to detect and easy to miss. And they're also difficult to completely remove. Up to 30% of the time, they're incompletely removed when they're large. They turn into cancer more quickly, 3 to 5 years, and hence they're responsible for many interval colorectal cancers. And especially since they are frequently misclassified as innocuous or innocent hyperplastic polyps, which results in an inappropriately long surveillance recommendation. So here's a diagram of that kind of perfect storm. If we miss a polyp, then we may recommend a colonoscopy, the next colonoscopy, too long from now. If we incompletely remove a polyp, then a patient can still get cancer. But if a pathologist classifies a polyp as inappropriately as a hyperplastic polyp, then we may still recommend an interval that's too long, even if the polyp was completely removed. So there's a lot of dependency on the gastroenterologist as well as the pathologist on whether patients get the appropriate interval recommendation. Well, that brings us to near the end of the colorectal cancer part of the presentation, but the recommendations are as follows. In terms of screening for colorectal cancer, for patients with no family history, the current recommendation is to start at age 50 or 45 in African Americans. Adults that have bleeding symptoms and at any age under the age of 50 should undergo a colonoscopy. And I can't stress this enough. Any person of any age who has rectal bleeding should have a colonoscopy, irrespective of how young they are. In someone who has had prior negative screenings, The guidelines say to consider stopping at age 75 or when their life expectancy is less than 10 years. And in someone who has never been screened, then they recommend to consider screening up to age 85. The methods of screening are as follows, and we kind of went over this already, but the most highly recommended tests, of course, are colonoscopy, but mainly for cost sake, an annual stool test is also recommended as first line. But remember, the key here is to do it annually. The performance of this test has only been measured when it's done annually. In patients who have a family history, it gets a little more confusing. So if there's a first degree relative with colorectal cancer under the age of 60 or two first degree relatives at any age, then they recommend starting the colonoscopy at age 40 or 10 years younger than the age of diagnosis of the relative, and whichever is earlier, and to perform at least every 5 years. If there's a first degree relative with colorectal cancer or advanced polyp greater than the age of 60, then they still recommend starting early at the age of 40, but then to perform the subsequent exams at the normal screening interval for average risk patients. And I also want to stress on this slide, not only does colorectal cancer count as a family history, but a history of advanced polyps. So conversely, those of you that have had colonoscopies, because I know many of you are seniors, those of you that have had colonoscopies who have had polyps, it's actually important for you to know whether your polyp was advanced. And that might not ever be communicated to you, but if a polyp was greater than 1 centimeter or had any of those advanced features, that's really considered an advanced polyp. And then that actually affects the time and the interval at which your children and your offspring will be screened. So it's extremely important for you all to communicate this information to your family members. These guidelines are slowly being updated. In 2018, the American Cancer Society was the first society to recommend lowering that age from 50 to 45. And until just recently, they were the only society to make that recommendation. But this is hot off the press from actually this week, and this was all over the news this week, and this was in light of Chadwick Boseman's recent colorectal cancer death at a young age. The United States Preventive Services Task Force, which is the major guideline by which insurance companies follow, and finally announced that in the draft of their new guidelines that will be released soon, they recommend screening for colon cancer starting at age 45. So this is brand new information as of this week. So this will be a significant change for us for the better. If there's a history of polyps, then the type and the number and the size of the polyps determines when the next colonoscopy should be. These are the most updated guidelines as of 2020, in that 1 to 2 small polyps should be followed up in 7 to 10 years, probably 7 years. 3 to 10 small polyps, 3 years. Any larger advanced polyps, large means again greater than 1 centimeter, 3 years. Any polyps, any person who has greater than 10 polyps or very large polyp should have much more frequent colonoscopies. But remember, if a patient has only hyperplastic polyps or no polyps, then 10 years. But again, these hyperplastic polyps can sometimes be misclassified by pathologists. If a person has had colorectal cancer, then we recommend the 1-3-5 rule. Repeat colonoscopy 1 year. If negative, then 3 years later. Then if negative, every 5 years indefinitely. So to summarize, what are things we can do to reduce our risk of colorectal cancer? We can get screened regularly, which is the most important. We can maintain a healthy lifestyle, a healthy weight, healthy diet, minimize alcohol, avoid smoking. But the true secret to prevent colon cancer is to find and remove all polyps or adenomas and leave no adenoma or portion thereof behind. The quality recommendations that our society has for us is that we should be detecting polyps in at least 30% of men, 20% in women, over 20 and 25% of patients overall. We should be getting to the cecum, or that upper part of the colon, at least 95% of our exams. We should be spending a good amount of time, enough time examining the colon, at least 6 minutes, and greater than 85% of our patients should have a good prep quality. And again, our societies recommend to you all that you should be asking these questions to your gastroenterologist, especially their adenoma detection rate should be at least 25%. Consider having your exam unsedated. It does provide greater transparency in that when you're watching your doctor, they're going to likely spend longer and have a more careful technique. But when you watch your own exam, you can drive home, you can go back to work the same day. There's no recovery time and there are no risks of sedation. So strongly consider that. So colorectal cancer, there's just no ifs, ands, or buts about it. So let's switch gears a little bit. I won't spend as long talking about reflux, but this is another topic that I care deeply about. And there are some really exciting developments in this field. And don't worry, there'll still be some time for questions at the end. Let's talk about reflux, but before we talk about it, it's really important to understand the anatomy of the gastroesophageal junction, and that there is a valve between the esophagus and the stomach that's supposed to act like a one-way valve. This one-way valve is supposed to allow food and liquids to go down in the stomach, but it's supposed to prevent acid and other stomach contents from going back up into the esophagus. But when this valve inappropriately opens, then acid and other stomach contents are then allowed to go into the esophagus. And that's called gastroesophageal reflux disease or acid reflux. There are various symptoms of GERD or reflux, and those can include heartburn, chest pain, regurgitation, trouble with swallowing. But there are many atypical symptoms, and I won't read through these, but I'll let you go through them. And if you have any of these symptoms and your physician can't understand why, or if it's just not getting better, you may actually have acid reflux. That's kind of sometimes thought of as silent reflux or laryngopharyngeal reflux or atypical GERD. Acid reflux not only results in bothersome symptoms, but is one of the biggest risk factors for esophageal cancer. And esophageal cancer is the cancer that's the most fastest growing cancer in incidence in this country right now. So here's the risk of esophageal cancer in this country over time versus many other cancers, which are not growing nearly as quickly as esophageal cancer. And this is occurring in both the incidence of cancer as well as the deaths from esophageal cancer. And that the esophageal cancer has one of the worst prognosis. Left untreated, acid reflux can progress to more serious conditions. It could result in esophagitis or inflammation of the esophagus, but more serious complications include ulcers in the esophagus, bleeding, strictures or narrowings, precancerous conditions called Barrett's esophagus, or esophageal cancer. And the journey that patients take in their treatment for acid reflux includes the following, and many of you likely have this disease, and many of you have likely gone through this journey of starting off with lifestyle modifications, then starting with medicines, including over-the-counter and prescription medicines. But many of you have likely seen that the effectiveness decreases over time, and there are various procedures that can help with this problem, which we'll talk about in just a bit. There are various types of medications for acid reflux, including over-the-counter antacids, H2 blockers such as Zantac, Pepcid, famotidine, ranitidine, cimetidine, or Axid, and PPIs or proton pump inhibitors such as Prilosec, omeprazole, Prevacid, Dexilant, Nexium, Protonix. These are proton pump inhibitors. These medications are effective for controlling reflux symptoms, but they do come with downsides, including side effects and complications. I won't go through this in detail, but this has been all over the news that there have been various types of side effects that have been raised and various concerns that have been raised about long-term use of proton pump inhibitors. That being said, in 2019, the first randomized controlled trial for assessing the side effect rates of proton pump inhibitors was performed and showed that most of these were not present in this randomized controlled trial. So they likely are pretty safe, but there's still a significant heightened awareness and concern about the potential long-term risks of proton pump inhibitors. But pills in general are not a long-term solution for reflux. The pills suppress the acid, but again, as I explained to you, acid reflux is a mechanical problem. The mechanical problem is that the valve between the esophagus and the stomach is too loose. And the only way to address the underlying problem is to undergo a mechanical repair of this issue, which restores normal anatomy and recreates an anti-reflux barrier, but still allows for normal function. So what's on our wish list and what's on your wish list? Well, what's on yours is that you wish you could feel normal again. You wish you could get a decent night's sleep and not take pills anymore. You want a less invasive surgery and no side effects. What do we want? Yes, of course, we want you all to feel better, but we also worry about long-term medication use. We also want patients to be satisfied, and we also want to make sure that long-term complications of reflux are mitigated by whatever treatment we choose. And there's a spectrum, like we mentioned, of these types of treatments, from lifestyle changes to medications. But let's talk about some of the more anatomic corrections for acid reflux, including something called the TIF procedure and conventional surgery. As you see here, of the 6.7 million people with GERD sufferer who are GERD sufferers, only a very small percentage of them elect to go through surgery. And the greatest fears are the invasiveness, the high complication rates, and the side effect profiles of acid reflux surgery. So this is the most conventional, traditional way of performing acid reflux surgery, which is called the Nissen fundoplication. And this is usually done laparoscopically with cameras into the abdomen, where a surgeon takes the fundus or the top of the stomach, wraps it around the bottom of the esophagus, and secures it with sutures. This is highly effective for controlling reflux, but as you can imagine, this procedure serves more like a barrier rather than a valve. And so there's a potential high rate of side effects from this procedure, which we'll talk about. That's what has led developers to come up with newer, more minimally invasive, potentially safer methods of controlling reflux. One is called the LINX procedure, where a surgeon still does laparoscopic surgery and places a ring of magnetic beads around the bottom of the esophagus, which is supposed to expand as food goes past it, but is supposed to stay closed as acid tries to come up the esophagus. This has been very effective to control reflux, but some downsides include that it's a foreign body in the body. The foreign body includes magnets, and hence, because there are magnets inside the body, certain MRIs cannot be performed, like let's say an MRI of the brain or spine needed to be done. And about 5 to 8% of patients still have some difficulty swallowing with this procedure. So this leads me to introduce something called the TIF procedure, which I have been performing for the last few years. And I was the first community gastroenterologist in Orange County to perform this procedure. This procedure stands for transoral incisionless fundoplication. So transoral means through the mouth. Incisionless means no incisions. There are some caveats to that though. Fundoplication is actually the same term used for that conventional surgery because it operates on many of the same surgical principles, but as you'll see, has been found to have much fewer side effect profile. What we do during this procedure is we insert a device down the mouth when a patient's under general anesthesia, and we retract tissue from the top of the stomach and we pull it down to lengthen and tighten and essentially reconstruct the bottom of the esophagus and create a new valve between the esophagus and the stomach. Here's a short animation showing what we do during this TIF procedure. The device is inserted through the mouth under the guidance of the camera. Tissue is retracted down to lengthen the esophagus and tighten it, and the valve is reconstructed using these non-absorbable polypropylene fasteners, which are like non-absorbable sutures. This procedure has been shown to be highly effective. Over 80% of patients were able to completely stop their daily proton pump inhibitors, and about 80% of patients were found to have complete healing of their inflammation on follow-up endoscopies. And we see that there's long-term data now showing durable results at 5 and 10 years, showing durable improvement in heartburn and regurgitation and remaining off of medications. And this is probably the most important slide when it comes to talking about anti-reflux procedures and why this matters, why this new procedure called the TIF procedure matters when we are comparing conventional anti-reflux surgeries or ARS. And we see here that the long-term side effect profile in anti-reflux surgery, such as Nissen fundoplication, is very, very high, up to even 50–80% of patients can have trouble with swallowing, gas and bloating, flatulence, and diarrhea. Again, these are with the more conventional Nissen fundoplication. And as you see here, these rates are not, they're not reportable because they're less than 1%. They are not higher than the placebo rate. So essentially the rate of these long-term side effects with these new procedures like the TIF procedure less than 1%. It's important to, again, understand the anatomy between the esophagus and the stomach, and that there are actually two valves. There's the opening in the diaphragm, and there's the lower esophageal sphincter, both of which block acid from going up into the esophagus. The reason this is important is that procedures like the TIF procedure repair this valve, but they do nothing to repair the opening in the diaphragm. Patients who have had long-standing reflux often have something called a hiatal hernia, which is when part of the stomach gets pushed up into the chest, and that's caused by an abnormally wide opening in the diaphragm. And so patients who have had reflux for a long period of time will often need a concurrent laparoscopic hiatal hernia repair, where a surgeon will go in still laparoscopically and do a minor surgery where they repair the defect in the diaphragm. I think this is one of my last slides. Here's an example of one of my own patients who had a greatly successful procedure where before she had her TIF procedure, her junction was wide open. I performed the TIF procedure and reconstructed her valve, and immediately post her procedure, her valve was nice and tight and robust. And when I looked at her valve 6 months later, I still had durable results. And here's a pH study that we performed before and after the procedure, showing that all of these red spikes below this line signify acid reflux that this patient was having before the procedure. And as you see here, there are almost zero red spikes after her procedure. And in essence, if you look at the numbers at the bottom of the screen, her acid reflux was completely resolved and she was able to completely eliminate her medications. So in conclusion, acid reflux or GERD is a mechanical problem of looseness of the junction. It results in symptoms, but it also increases the risk of complications such as strictures or narrowings, and especially esophageal cancer. But acid reflux has various types of treatments, including lifestyle, medications, procedures, and surgeries. But the procedures and surgeries are the only way to treat the underlying mechanical problem. The TIF procedure is a newer procedure, though it was FDA approved in 2007. It provides a good balance between effectiveness, minimally invasiveness, and minimal long-term side effects. Thank you very much for the opportunity, and I'm happy to take any questions from you.